shift to the Professor Dr. Nesma Safwat, Professor of Clinical Pathology, Ain Shams University. She's going to talk about the procoagulant platelets from thrombosis to future therapeutic opportunities. Thank you.
Thank you, Dr. Nagir. Thank you, Dr. عزة. الحقيقة أنا مبسوطة جدا إن أنا موجودة النهاردة، ولازم أشكر في الأول الأورجنايزرز، وكمان أشكر دكتورة نيفين هي اللي ادتني الشانس إن أنا أبقى موجودة النهاردة، وكمان إن أنا أبقى موجودة وسط فيجرز الحقيقة يعني الواحد بس كان بيسمع عنهم، ف I'm very proud إن أنا النهاردة وسطهم وبعمل presentation. Thank you. خلينا back to platelets مرة تانية وامتدادا لمحاضرة الدكتورة نيفين. النهاردة إن شاء الله هتكلم على procoagulant platelets. الحقيقة إنه ده كان من ضمن التوكس اللي أنا كنت محضراها للترقية، بس الحقيقة ما تمش اختيارها، وأنا من كتر ما لقيت الموضوع very interesting الحقيقة إن أنا عملته فعلا presentation، وحبيت إن أنا أبتدي أتكلم عنه لأن هو مش بس interesting لينا إحنا ككلينيكال باثولوجي، لكن برضو هو إن شاء الله هيبقى مهم في النكست فيوتشر للكلينيشنز، لانه في بعد ليه علاقه بالثيرابيوتيك opportunities، فهو مهم برضو للكلينيشنز. Advances in the field of platelet biology provides a better understanding of platelet functions and subpopulations. Recently, procoagulant platelets have been identified. Among their unique features is its ability to mount and sustain a procoagulant response. So, targeting procoagulant platelets may lead to a novel therapeutic direction in diseases of thrombosis and hemostasis. These are the topics that are going to be covered in today's presentation, and I hope you find it informative and interesting. Now let's start with an overview of procoagulant platelets. Platelets are small enucleate blood cells. They are unique in their structure, having a cytoskeleton maintains its discoid structure, a plasma membrane composed of phospholipid bilayer, two major alpha and dense granules, as well as distinct mitochondria. Heterogeneity of platelets characteristics is noted upon activation and within hemostatic plug, and this is promoted by, first, extrinsic factors including local availability of platelets agonists, vascular environment, and interaction between platelets and other cells. In addition to intrinsic platelet-specific factors including platelet size and age, levels of membrane receptors, and granular proteins. Accordingly, platelets greatly differ in their reactivity, and this is responsible for their functional specialization among showing distinct platelet subpopulations. Dependent on the strength of an activation triggers, two subpopulations of platelets have been identified, the aggregatory and procoagulant platelets. Activation of discoid platelets by weak or moderate stimulus generates the aggregatory phenotype, which is characterized by pseudopodia formation, integrin activation, and granule secretion. While in response to strong agonist, the aggregatory phenotype turns to become procoagulant platelets. Procoagulant platelets have unique functional and morphological criteria, including their generation is in response to strong agonists, such as high concentration of thrombin, high concentration of collagen, and co-stimulation by collagen and thrombin. Externalization of phosphatidylserine on their outer surfaces. They support assembly of coagulation complexes such as the tinase and prothrombinase complex. They have also alpha granule protein on their membrane such as factor V, fibrinogen, fibronectin, and von Willebrand factor. They have sustained cytosolic calcium rise in addition to impaired platelet adhesiveness. So procoagulant platelets can be categorized into two main categories. The first category is the balloon platelets. They are distinguished by their balloon-like appearance, and this ballooning occurs due to disruption of cytoskeletal elements and increased salt and water entry. They also function as a catalytic surface for thrombin generation. The second phenotype is formed after stimulation by collagen and thrombin, so it has been termed as coat, and the word coat is referred to collagen and thrombin. They bind several alpha-granular proteins which cluster to form an immobilized coat, and also they act as anchoring points for fibrin formation. The common character of the both phenotype is the presence of high level of phosphatidylserine on their external surfaces. Now let's know the role of procoagulant platelets in thrombin formation. At the site of vascular injury, tissue factor triggers the initial generation of thrombin, which stimulates the formation of procoagulant platelets, leading to amplification of thrombin generation at the surface of balloon platelets. And this generated thrombus will further activate the intrinsic coagulation pathway, and at later stages, the fibrin network will expand on the outer surface of the thrombus. So these findings suggest that procoagulant platelets can link the primary hemostatic platelet aggregate with the onset of secondary hemostasis, mediating fibrin generation and thrombus stability. Let's look at this figure. This is within a thrombus in a damaged blood vessel. We can see here the aggregatory phenotype inside the core of the thrombus. They have formed pseudopodia and they have undergone secretion. While procoagulant platelets are close to collagen fibers here and also present as patches around the thrombus. Then they are squeezed to the periphery by their contracting pro-aggregatory neighbors. They are squeezed to the periphery of the thrombus. And finally, they define the edge and boundaries of the hemostatic plug. So taken together, they work in concert. The aggregatory phenotype will tightly seal, and the procoagulant platelets will delineate the site of vascular injury in preparation for wound repair. Now, a very interesting question arises: how a platelet becomes procoagulant while another one does not? To answer this question, we have to go deeper and deeper inside the molecular events underlying a procoagulant response. After potent platelet activation, cytosolic calcium rises here, and this activates downstream signaling, leading to a procoagulant response. These events are three main events. The first event is the formation of mitochondrial permeability transition pore, and this pore is non-selective pore spanning the mitochondrial membrane that allows small ions and molecules to enter inside the mitochondrial matrix, leading to loss of mitochondrial potential and shutting down the proton gradient necessary for ATP generation. So the ATP is going to be depleted, leading to that the mitochondria will be unable to maintain its electrochemical potential anymore, leading to entry of more and more ions, leading to increased volume matrix, mitochondrial swelling, and ROS production. This oxidative stress will facilitate oxidative modification of membrane protein, leading to loss of membrane integrity. The last event that since the intracellular calcium channels that link it to calcium control are ATP dependent, so ATP depletion will lead to exacerbate the cytosolic calcium rise, leading to a protease activation, cytoskeletal protein disruption, loss of membrane integrity, and phosphatidylserine exposure, which is the conical feature of the procoagulant phenotype. Since phosphatidylserine is a conical feature of procoagulant phenotype and cell death, so it's not surprising that cell death pathways have been explored in relation to procoagulant phenotypes. Both necrosis and apoptosis have a potential role in regulating procoagulant response. For more understanding, we have to ask ourselves a very important question. Phosphatidylserine is a common feature of apoptotic cell, necrotic cell, and procoagulant platelets. So, procoagulant platelets, are they apoptotic or necrotic? recent advances in the molecular biology of platelets suggest that many of the features observed during necrosis have been observed in procoagulant platelets, while apoptosis plays a key role in clearing aged platelets from the circulation. For better understanding خلينا نبص كده على السلايد دي هنعمل فيها مقارنة بين الابوبتوزس والنكروزس والبروكواجولانت platelets. الايجينج اوف platelets بعد 7 ل 10 ايام من اللايف سبان بتاعت البليتلتس الانترنسيك apoptotic pathway is going to be activated by libration of pro-apoptotic molecules called BAG and BAGs. They will form pores on the outer mitochondrial membrane, leading to mitochondrial outer membrane polarization. This is followed by cytochrome C release, caspase activation, and well-characterized morphological changes characterized by membrane blabbing and phosphatidylserine exposure. Phosphatidylserine provides the major eat me signal. ال eat me signal for phagocytes علشان تعمل phagocytosis للaged platelets. While in necrosis, molecular events اللي بتحصل في النيكروتيك cell هي نفسها اللي بتحصل في البروكواجولانت platelets, requiring increased cytosolic calcium as an initiating stimulus, followed by mitochondrial dysfunction, calpain activation, loss of membrane integrity, and phosphatidylserine exposure. اللي أنا عايزة أقوله من السلايد دي والconclusion بتاعها هي حاجة مهمة جدا. إن الapoptotic pathway leading to phosphatidylserine exposure is completely distinct from the pathway leading to phosphatidylserine positive procoagulant platelets. So it is concluded that apoptosis is associated with clearing aged platelets from the circulation, while necrosis at the site of vascular injury will promote thrombin and fibrin generation required for both hemostasis and vascular repair. إزاي أقدر أعمل assay للبروكواجولانت platelets? We can do so by flow cytometry based method using a combination of cell death marker and platelet activation marker اللي هو ال P-selectin. It was explored to distinguish necrotic from apoptotic platelets. All platelets are defined as events that are negative for CD41A and positive for CD45. The red quadrant outlined in red will contain the procoagulant phenotype, which are positive for P-selectin and cell death marker, while the quadrant outlined in green is the apoptotic quadrant. It will contain apoptotic platelets negative for P-selectin but positive for the cell death marker. After co-stimulation with thrombin and collagen, a significant proportion of platelets will show the procoagulant phenotype. What is the clinical role of procoagulant platelets in diseases of thrombosis and hemostasis? In fact, normally 30% of platelets become procoagulant on average. There are differences between individuals' platelets capacity to become procoagulant after maximal stimulation, and this is termed as procoagulant platelet potential. Recent clinical studies have suggested that individual differences in procoagulant platelet potential are linked to hemorrhagic and thrombotic phenotypes in many disease states. Now, let me show you some of these recent clinical studies all over the world, starting with hemostatic disorders. This was a poster presented in the annual meeting of American Society of Hematology. It concluded that there is an inverse relationship between procoagulant platelet potential and phenotypic severity in hemophilic patients. And this original article showed for the first time that a significant proportion of patients with bleeding diastasis with normal conventional laboratory workup may be due to isolated impairment of procoagulant platelet generation. Prodan and his colleagues in their recent research work concluded that lower procoagulant platelet levels were associated with acute hemorrhagic complications after ischemic stroke. As regards thrombotic disorders, This original article demonstrated a heightened procoagulant platelet response may provide a deeper insight into the thrombotic risk in coronary artery disease patients. And lastly, this study suggested a significant role for procoagulant platelets in risk stratification of stroke patients after transient ischemic attack. So please remember that the quantitation of procoagulant platelets may provide the prediction whether a patient has a tendency to bleed or will be at risk of thrombosis. The most interesting part of my presentation for today is the therapeutic potential of procoagulant platelets. In fact, platelets are considered as a major target for pharmacotherapy. Current antiplatelet drugs have a rise in bleeding complications, and some patients still have ongoing serious vascular events. So, alternative targets for management of thrombotic events are still needed. Blocking the molecular drivers of procoagulant platelet response is a novel antithrombotic approach. It selectively limits thrombosis and spares other essential platelets aggregation and secretion. Cyclosporin is known to be a mitochondrial permeability transition pore inhibitor, and acetazolamide blocks water entry to prevent ballooning in vitro. Exploring the effectiveness of these drugs in vivo is a challenging target in the next coming future. My take-home messages for today. Procoagulant platelets have unparalleled ability to support the coagulation reactions. Procoagulant platelets assay may resolve unanswered questions in disorders of thrombosis and hemostasis. And finally, modulating procoagulant platelets potential may represent a novel therapeutic target in the coming future. Thank you for your attention. Thank you.